Well, for Dr. Peterson, Dr. Pomps, thanks so much for inviting me. Usually when I give a talk towards the end of a session, I hope the speakers in front of me really suck so I could look good. And that's really not the case here. The first three talks were phenomenal. And this has actually taken on a fairly personal meaning for me because Dr. DeMaria used to be about 10 minutes from my hospital. And I used to love to send him all those patients to do revisions on. And now that he's gone, I don't have that option, so I'm really, really mad. And I'm going to take it out on him. These are my disclosures, which have nothing to do with what I'm talking about today, but this does. I'm retiring in 8 months, so there's absolutely nothing I can say or do today that's going to affect me professionally or personally. So surgery this is the 1991 consensus conference we all know and we live by. Surgery is the only approach, blah, 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 blah. Historically, that's how obesity was treated. Then all of a sudden we had morbid obesity, and we decided surgery was the tool. It's the hammer. We realize now that that's not the case. We need multimodal management. It's not just a surgery, but that became sort of the gold standard. And as we all know, surgery is good, but it's not great. And this is the SOS trial, which has phenomenal long-term data. And you can see that there's very good weight loss at 1 year. And over time, the weight loss decreases. So there is a certain amount of recidivism, and this is probably the best data we have. The problem is why? And we really don't have a good chance to understand it. We're working hard, but this was a paper in 2012 that looked at lifestyle habits, food patterns of patients who went bypass. And please understand, I'm talking specifically about bypasses today. The last talk about sleeves, I think that the bypass is a terminal operation for weight loss. The sleeve is a step. So I really, this is about bypasses only. And they want to look at predictive factors. The bottom line is that this is their study. Weight loss was 60%. There's a lot of weight regain. 56% of patients regain weight back. 29% regain more than 10%. And over time, it gets worse. This is 14.7% of patients at 2 years, 70% from 2 to 5, and 85% patients at 5 years. So what makes people gain weight? Poor diet. Pretty obvious for all of us. Sedentary lifestyle. A lack of nutritional counseling and follow-up. So the question comes down to, did the patient fail the surgery, or did the surgery fail the patient? We do revisions for a lot of reasons. Complications, weight loss, inadequate, and recurrence and inadequate resolution. And we're not going to talk about complications because that's a no-brainer. We all do revisions for complications. That's part of what we do. It's part of what we should do. What about the patients who don't lose enough weight or gain weight back? Again, if their weight loss is, they're unhappy and they've got mechanical or anatomic abnormalities in a large pouch, this always does this for some reason. It shows a large pouch, but that's a better picture. If they've got a really enlarged pouch, which is now 75, 80, 100, 200, whatever the number is, they should have it revised. If they've got a gastrogastric fistula, they probably should have some revision done, if it's a huge gastrogastric fistula. But what about the patients who don't have a metabolic or anatomic abnormality? Again, surgery is the only approach that provides weight loss. We are surgeons. The surgery failed. Therefore, we should operate again. Band over bypass. 28 patients had a band over bypass. 24 patients had a dilated gastric pouch. Follow-up was 38 months. Long operative time, a lot of complications, 4% conversions, long hospital stay, a high reoperative rate to have the bands removed later on. A lot of adverse events. Weight loss was not so great. And they went on to say, laparoscopic placement of an adjustable band around the gastric pouch after bypass failure is technically challenging, which we all agree with, carries significant morbidity, may need subsequent surgery, and is only associated with a 12.7% additional weight loss. So I think we can pretty much agree that band over bypass probably should not be done. We've all tried it. It was miserable. It didn't work. Let's not do it anymore. What about patients who have a big stoma? A lot of talk about that. Stoma fix versus a sham procedure, randomized double-blind study. How are the results? Closed prematurely for failure to achieve primary efficacy endpoint of at least 50%. Early termination of the study. The ASMBS put out a revisional guidelines back in 2013, retrospective review. The procedures are well tolerated, okay, but they're not very effective, and a lot of devices that were talked about are no longer on the market. So what does that tell us? Bad devices or bad operation? What about a pouch being too big? This is a midterm outcome, nice paper, 25 patients. Laparoscopic revision, resize the gastric pouch and downsize the gastrojejunectomy, almost sleeving the anastomosis in the pouch. And they had statistically significant weight loss at 12 months. And here's their data. Patients lost 70%. We're all happy with that. Now they're down to 40%. Unhappy. Let's go ahead and revise them, make their pouches smaller, back to 64%. That's fantastic. Look at them in 2 years, back to 42%. Is it really good? Short-term weight loss, but is it really effective long-term? Probably not. Retrospective review of 20 patients who underwent pouch resizing, complications in a lot, follow-up at 20 months, weight loss was 69%. And they said, their conclusion was, pouch resizing has been shown to be a valuable option for weight loss failure or regain in patients with a dilated pouch. Dan Heron, and I'm not sure if he's in the audience, but Dan is very well known, very well respected, and very thoughtful, had a great editorial comment. The net BMI loss was only 6 units. Laparotomy was required in 10% of patients. 15% leak rate, 10% pulmonary embolism rate, and at 12 and 18 months follow-up, there was evidence of weight regain. Although many surgeons believe that a chance to cut is a chance to cure, we need to very carefully weigh the risks of this type of revision against the benefits. Careful inspection could show that without clear and significant clinical indications, it's just not worth the risk. What about making longer limbs? This is a nice review of 29 patients. And this is also a table from that report, and the top row is their patients, but look at the different common limb lengths all over the place. There was good BMI decrease, but look at the incidence of protein-calorie malnutrition. And they went on to say that the development of protein-calorie malnutrition and vitamin deficiencies is real, and patients require close monitoring and follow-up. I'm actually in a very unique position. I've got what's in front of me is the holy grail of debate. I get to take Dr. DiMaria's paper that hasn't been published yet and use it against him. I mean, this is like a once-in-a-lifetime opportunity. This is Dr. Maria's paper that's coming out soon that looked at conversion of standard gastric bypasses to distal bypasses. And he's got some very nice conclusions. Revision of proximal gastric bypass to distal bypass results in substantial improvement of weight loss and resolution of comorbidities at 3 years. He's going to talk about this. I'm sure he's going to tout this as this is the best thing since sliced bread. But in his conclusion, Dr. DiMaria is pretty honest. He says, nevertheless, patient counseling and close monitoring post-revision is critical. And we recommend a low threshold to operate to lengthen the distal limb now in patients who develop progressive deficiencies. So Dr. DiMaria, he's a brilliant guy. I mean, I love this guy. Patients have weight gain. What do? You shorten their common channel. Perfect. They lose weight. You're happy. They're happy. Oh, no. Malnutrition. What do? You lengthen their channel. Oh, they gain weight. So if you guys stick around later on, Dr. DiMaria is releasing his new book, How to Make Money with Only One Patient for Dummies. Notice at the very top, this book is endorsed by Dr. Pomper, who says no one should ever be a surgeon without reading this book. And I think if you have a couple of bypass patients, you can probably live the rest of your life by lengthening and shortening your limbs. And Dr. DiMaria will be signing these copies for you afterwards. So, are revisions good? This is a review of bypasses and sleeves. I'm not going to bore you with the details, but OR time is longer for the secondary procedures. Length of stay is longer, more complications, more leaks, more mortalities. We've worked really hard to get our mortality rates for bariatric procedures down below 0.3%. Now with revisions, they're 1.3%. I think no one would think this is a good idea. Revisional procedures carry a higher complication reoperative rates in comparison with primary operations. Weight loss achieved is inferior. And we really should treat these operations with caution. This is the bold data, looking at revisions. And again, look at those complications, all statistically significant mortality, significant events, compared to the primary operation. This is a really nice review article, which is from 2011 about revisional bariatric surgery, and Dr. Kellogg said very simply, it should be considered and accepted that, as with many other diseases, not everyone can be cured of their obesity. There's a group of non-responders who are resistant to weight loss despite the surgeon's best efforts. We've all heard this before. It didn't work the first time, we do it again, we're insane. Now, I don't think we should be, if it's anatomically induced recidivism, they need an operation. However, if they're in this position with no anatomic abnormality, they should not have surgery. So in the beginning, what can we do as surgeons to plant the seeds for success? We say it a million times, but they need to understand this is a tool, it's not a magic bullet. You need long-term lifestyle changes and accountability, which is so hard to get. They need to adhere to guidelines, group support, physical activity for the rest of your life, not just for a couple years. You've got to set goals, realistic goals to the initial visit. You have to change behaviors prior to surgery, which is why in our program, if anybody gains weight before they have surgery, we cancel their surgery. Because if you go to our classes and it's a 3 to 4 month process and you do the bare minimum, you should never gain weight before surgery. And if you do, you haven't made the changes. And the patients we've canceled, patients are never unhappy when they come back 3, 6 months later, go, you know what, I didn't get it, I'm ready now. And again, you need a plan, a long-term plan for maintenance and for weight loss. And again, personal accountability. We've all talked about patients not coming back. This is a huge, huge problem. So you get patients to re-engage, and again, non-judgmental. You need all of your members. This is not just us. It's it's bariatricians, it's the exercise physiologists. I think the behavioral specialists are critical in this area. You got to have a supportive and a firm, but an empathic, non-confrontational setting. Don't tell them it's okay that they screwed up, if you want to use those terms, which I wouldn't, but just say, we're in this together. I'm glad you're here. Yes, you didn't come in for 10 years, but at least you're here. Now we can do something to help you. This is a literature review to look at the incidence and causative factors. A lot of papers, a lot of patients. Underlying etiologies are incredibly complicated, multifactorial, and overlapping. And we don't understand why patients, whether it's hormonal, whether it's set points, I don't get it. But a dedicated weight recidivism clinic that offers patients a methodical, organized, and multidisciplinary plan may serve as a useful template for practitioners dealing with weight recidivism post-bariatric surgery. So again, here's the historic management of recidivism. I think we can agree that for the bypass patients, this does not work. They need a back-on-track program. We are very fortunate in our institution to have 17,000 square feet in one building. We've got a surgical and medical weight loss program in the building, and it's supported by all of these different people, and a small gym and a store that all are in our facility. We're very unique and very fortunate. So here's the way it works. Unsatisfied with weight loss. We go to a seminar, we discuss things. After that, patients always get an upper GI. If that's abnormal, they enter the surgical program. This is anatomically induced weight gain. If it's normal, they go to our Back on Track program if they want to. They then meet with our bariatrician, a comprehensive 1.5 hour appointment, and they attend a 15-week Back on Track session. This is a wonderful article by our own Dr. Pomp, who actually looks at drugs. Our prior bariatrician who left during the summer was not very drug-friendly, but our current bariatrician is very drug-friendly. I think drugs are going to have a tremendous, tremendous role with newer medications coming out in the treatment of weight gain or weight regain after bypass or after any bariatric operation. This is our 15-week course. You can see that most of our topics are psychology related, but there's a handful of nutritional ones and a handful of exercise ones. Patients pay $100 to come into our program. I'm a firm believer in bribing people. This is our store. And after 5 visits, whoops, I'm sorry, I should go back. After 5 visits, they get a coupon for 15% off in our store for any one time they want to come in. When they finish their 10th visit, they go another one. When they get to their 15th visit, they get another one. So we're bribing people to be good. We also do this now for our patients who come back yearly, and hopefully in the future we'll be able to present some data that bribing people to come back with a financial incentive, which sounds unappealing, is actually going to work. Demographics, we had 67 patients so far who have gone through the program. Age is what you expect, 80% are females. Initial weight, and I apologize for not having some percentages, but I just ran out of time getting this together. The lowest weight was average 184. Most patients had lost up to 91 pounds on average. It took about 3 years to get to their lowest weight, but some patients did that quickly and didn't get very low. By the time they came to their back on weight program, the average weight was 221, and the average weight loss was about 35 pounds. So it's not huge, but a lot of patients never lost as much as they would have liked. Our preliminary data, again, 67 patients have completed our first 7 sessions. We've got an attendance rate of 70%, which I think is reasonable, but not as high as I'd like. We have got good follow-up because we've got an EMR. So even if these patients haven't come back to see me, I went into their EMR and saw their last doctor visit, and they're recorded in our system, so I can get their weights. So we have got 100% follow-up at 1 year. We've got about 90% follow-up at 2 years and 76% at 3 years. Obviously, the dots below the line are good. We like those lines. Those are very good. Those are people who lost weight, and this is what's happened during the course of the treatment. Average weight loss was 8 pounds. 10 patients gained weight, but 57 lost weight. Interestingly enough, if you look at the number of sessions they came to versus the amount of weight they lost, the more they came, the more they lost. Pretty common sense. We tell people that all the time. At 1 year, we're now starting to see some more weight regain, and again, we're seeing more numbers in the plus range above the bar, which I don't like. But again, if you go back to those percentage of patients who saw stuff, the more they came, the better they did. So it's something to really hammer home to your patients. At 2 years, we're not as good as we should be. And this is expected. We now have got, a lot of patients who have gained a lot of their weight back. And this is our 19-year data, our 75% data on 19 patients to 3 years, and we've got a couple people who have lost weight. Some that have kept off 35, 40 pounds, but most have gained weight back. It's really important to be honest about our complications. If we don't, we're not doing a very good job. That makes me feel pretty good. So in summary, those with normal post-surgical anatomy, they failed the surgery. They should not be offered revisional surgery. They may benefit from a back-on-track program. Gastric bypass is a safe and effective short-term operation, no question. But recidivism is significant and it's vexing. The problem is we have no idea how well our patients are doing because we don't have the data follow-up. A lot of different etiologies, numerous, multifactorial. Some patients, actually the surgery failed them. They should get revised. The problem is we have gotten very good laparoscopically. We are very talented surgeons. Dr. DiMaria has operated on patients that I would never touch, and they've done fine. But the complication rates are higher than the primary operation. And I've showed this video before. This is with regard to revisional surgery, and I apologize if this is offensive to anybody, but again, I'm retiring in 9 months, so I don't care. Just because you can't do something doesn't mean you should. So those with normal post-surgical anatomy, they failed the surgery. They should not be offered revisional surgery. They may benefit from a robust multidisciplinary back-on-track program. This is my personal belief. They've had a bypass. They've been successful. They've regained weight. There are no anatomically identifiable problems, and they're no longer following the guidelines. They are not a candidate for revisional bariatric surgery with regards to a gastric bypass. When the train falls off the track, you don't need a brand new train. You don't need a fancy train. Polish up the old girl and get her working again. And I think people will do fine. Thank you very much.